Good morning. I would like to thank the organizer for inviting me to report our experience with optical genome mapping on cases presenting with repeat expansion disorder and complex chromosomal rearrangements. We have been starting with this technique for a few months. And first of all, we decided to run 30 known samples just to see whether and how this platform could actually detect known imbalances. So we selected samples accordingly with their chromosomal or clinical indication, and we selected 5 samples harboring an unbalanced chromosomal rearrangement, 7 with a balanced chromosomal rearrangement, 7 cases with copy number variants, such as deletions or duplication ranging from 44 kilobases to 600 kilobases, 3 cases with nucleotide expansion, and in 8 of our cases we were interested in knowing whether in candidate gene there was some kind of structural rearrangement or small deletions, because these samples, these patients had a very clear and strong clinical indication suggesting a specific gene condition without a molecular characterization. During this presentation, I will focus my attention on 4 cases. The first one is a case with an unbalanced translocation, reciprocal translocation, and the 3 cases we have with nucleotide expansion. The first patient is a female, 6 years old, with a drug-resistant epilepsy and psychomotor retardation. Cytogenetic analysis disclosed a reciprocal translocation among the long arms of chromosome 2 and 18. Here on the right, you can see a FISH analysis with painting probes, green for chromosome 2 and red for chromosome 18, so you can see the translocation. We also tried the samples, processed the samples with array CGH, which disclosed a small deletion on the long arm of a chromosome 2. The deletion arose de novo, such as the translocation itself, so we thought that it could be the breakpoint of the translocation, even because it was exactly where we thought it should be the breakpoint for chromosome 2. It was 181 kilobases inside, and it's involving one known gene, a sodium channel gene, SCN2A. This gene is a disease-causing gene, and it is associated with epilepsy and psychomotor retardation. The strange thing is that normally gain-of-function variants in this gene lead to a severe early onset phenotype. Normally, loss of function or deletion, as in our case, result in a later onset phenotype and a milder phenotype. So it was strange that our patient, which was 6 years old, presented such a severe phenotype in association with the deletion of this gene. But as we know that this kind of phenotype is very variable, we thought that maybe we were in an extreme side of a broad range of phenotype. And we thought that this gene could be causative for our patient phenotype. We selected this patient for analyze it on optical mapping because we wanted to see whether the platform could be able to detect both the translocation and the deletion. And what we saw is that the rearrangement was actually more complex than expected. In fact, as you can see here with circle plot, we have an interchromosomal rearrangement with one breakpoint on chromosome 18, as expected for a reciprocal translocation, and 2 different breakpoints on the long arm of a chromosome 2. The region which is involved between the 2 breakpoints is inverted on itself. We can visualize these rearrangements in detail just by clicking on them. So here I'm clicking on the inversion. I can see immediately the breakpoints of my inversion, and I can visualize an enlargement of the region. So as you can see here, we have the inversion. The green segments are the references for chromosome 2, And our patient's molecules are represented as a blue segment in the middle. As you can see, this inversion disrupts a different sodium channel gene named SCN1A. This gene is not deleted, it's just disrupted by the inversion, so it's a new information that we didn't have before. What about our deletion? It is detected by this technique as well as this red line in the structural variant portion. And if we click on it, we can see an enlargement of the deletion. We can see that the size is more or less how expected, and that it involves SCN2A gene as already detected by array CGH. We can do the same thing for the other rearrangement. We can see the interchromosomal rearrangement and the two different breakpoints. We can open one by one. We can see the breakpoints and we can visualize the details, and we see that these rearrangements do not involve any known gene. The same thing for the other one. No known gene involved in the translocation. Again, you can see the references in green for chromosome 2 on the top and for chromosome 18 in the bottom. In the middle, we have the molecules for our patient. So what happened to our patient? The more likely is that 4 different breaks occurred on the 2 involved chromosomes. The first one on the long arm of a chromosome 18, and 3 further on the long arm of a chromosome 2. The first break, starting from the centromere, is where the deletion occurs, and 2 more distal breakpoints with the included portion which is inverted on itself, and the terminal portion of the chromosome which translocates with chromosome 18. So this is how it appears, our derivative chromosomes. And the most important thing is that here in the breakpoint of the inversion, we have the disruption of SCN1A gene. This gene is a disease-causing gene, a known disease-causing gene, which is associated with Dravet syndrome. This is an autosomal dominant condition, which is associated with epilepsy and psychomotor retardation with an early onset of seizures. So this gene fits very well with our patient's phenotype, and maybe is this one the real cause of our patient's phenotype, and not the deletion of the other sodium channel gene, which only partially could explain the severe phenotype presented by our child. The second patient that I would like to present is a patient presenting with a Friedreich ataxia. Friedreich ataxia is an autosomal recessive condition, normally caused by an homozygous repeat expansion in FXN gene on the long arm of a chromosome 9. The onset is normally during the puberty, and the first clinical sign is normally an hypertrophic cardiomyopathy. It is also associated with a severe ataxia, which is progressive with the age, and other signs such as optic atrophy or scoliosis. Our patient is a female, 9 years old. She only presented with hypertrophic cardiomyopathy at that age. We already knew that she had a Friedreich ataxia because a specific assay was performed detecting a homozygous pathogenic expansion in FXN gene. It was 2.5 kilobases in size. When we processed this sample with optical mapping, we saw that our patient also presented a large deletion on the long arm of a chromosome 9, which is inherited from her healthy father. The deletion involved several genes, including, of course, FXN. So one allele of this gene was completely deleted. And the software also detected the expansion as a blue bar. You can see it here. If we click on it, we can have the detail of this aberration. You can see that it involves the first portion of FXN gene. It is called by the software as an insertion. That's because the software see that the two neighboring labels here on the reference chromosome are a little bit more spaced on our patient, so it detected that something is inserted there, and it's actually our nucleotide expansion. So optical mapping allowed us to determine that in this patient, the phenotype was explained by an hemizygous nucleotide expansion, because one allele was completely deleted. The deletion was inherited from the father, and the other allele presented with the nucleotide expansion. Our second patient is a female, 15 years old. She also presented with an hypertrophic cardiomyopathy, but because of the age, she also presented with ataxia and scoliosis. She was no more able to walk. Again, a specific assay for Friedreich ataxia detected an homozygous pathogenic expansion in FXN gene, and it was confirmed by optical mapping. So you can see here the insertion involving the first portion of FXN gene. It is in homozygous status, so we can see both the causative events. The size, again, is 2.5 kilobases. The third patient is a patient presenting with a Fragile X syndrome. It is a X-linked syndrome caused by an expansion in FMR1 gene. This patient was already tested by a specific assay, confirming the clinical indication of Fragile X, and we wanted to verify whether such a small insertion could be detectable by this platform as well. And it was. You can see here we have FMR1 gene, and the first portion of this gene is involved in an insertion event, because the labels here on the reference are a little bit more spaced in our patient. It is reported as an homozygous expansion. Actually, it is in hemizygous status because we are on the X chromosome of a male patient, but the aberration could be confirmed by this technique. So in conclusion, we are very satisfied of the results we had by this technique, and we started to introduce this technique in our routine diagnosis. First of all, for characterize genetic aberrations, because as seen for the first patient I presented, it really can make differences in cases of complex rearrangements, where we want to identify the real molecular driver of a specific clinical condition. We are also using this technique in case of recessive pathologies, when, for example, we found a sequence variant in one gene that could explain a phenotype, but the pathology is recessive, so we need to identify the second hit. And we are using this technology to identify small deletions within the candidate gene or structural variants, which could lead to the expression of the phenotype. The same thing for autosomal dominant condition, when we have patients with a very strong clinical indication addressing towards a specific gene, which was not positive for a sequencing analysis. So again, we are interested in that analysis to see whether this gene harbors some kind of deletion or a structural rearrangement explaining the clinical phenotype of our patient. At last, we started a new project on children solid tumor, mostly brain tumors. So we have biopsies of these patients, and we want to run these samples on optical mapping to see whether some rearrangement, complex rearrangement is present, leading to the formation of a causative gene fusion, which could explain the acquired phenotype of these children. Thank you for listening.